So with the hopes of publishing it in some way in the future. I'll be using first names as I address you. Um, Everyone who attends will get a link to at least the slides. You'll get information how to contact myself or Chrissy. Many of you know Chrissy, my surgical coordinator, who I think is here today. And we can make arrangements to see you if you're interested in coming to Virginia. Basically, I'll be sending you all our contact information, so you don't have to worry about gathering it now. I'm going to start with the questions. I believe that all you need to do is type in your question, and it will be in a queue, and I will get to your question. And I promise to stay on pretty much till we get through everybody's questions. Okay, we're going to start with Dandoni. Dandoni has a ton of questions, so we're going to go slowly. Dandoni says, I really want to talk about the difference in results of FOV between induced PVD and core as you do. Some surgeons say core is useless because it will higher the chance of new future floaters. Also, an annoying frill could be seen. What is your opinion? My opinion is the people that are telling you this don't want to consider doing an FOV at all, because I don't agree with the rationale that you just presented. As I just said, doing an FOV without a PVD is safer for you, or I should say doing an FOV without inducing a PVD is safer for the patient. If and when a PVD does occur after vitrectomy, chances are you may not notice floaters. So I disagree with the fact that floaters are going to appear with every PVD. The annoying frill. I've never heard of frill until I became interested in discussing FOVs. I've never had a patient complain of frill, but I've had many questions about frill, and I believe those are patients that did not have enough vitreous left. It has been my experience that if you carefully perform the vitrectomy and remove most of the central vitreous, frill or residual floaters simply are not an issue. Dandoni asks, how many percent removal of the vitreous? How much vitreous do I remove? I'm going to say most. It's very hard to calculate how much vitreous is removed. By most, I'm estimating somewhere between 75 to 90%. Going above 90% makes the operation more dangerous, and you can actually start to run into complications. Eric asks, and this is a really good question, Eric, and I think we talked on the blog a little bit about this. Are patients with myopia more susceptible to retinal detachment during and after the operation? And will vitrectomy change the prescription? Patients who are myopic are not more susceptible to retinal detachment during the surgery. I don't believe retinas are any thicker or thinner or more prone to tear during the operation, but part of the operation is to look for tears that may have occurred during the operation. So that I would say that we are very good at detecting tears during the operation, so that what the real question is the ability to detect a tear any different in a highly myopic patient than a non-myopic patient? And the answer is no. Will vitrectomy change your prescription? Not directly, because it is not changing the shape of the eye. The definition of your prescription is heavily related to the length, technically speaking, the actual axial length of your eye. That's the distance between the surface of your cornea to the surface of your retina. Usually it's about 23.1 millimeters. Highly nearsighted people have a longer axial length. The reason I'm going through this detail is people that are myopic can get retinal detachments. They get an eye operation called a sclerobuckle, that can change the prescription. But a vitrectomy alone does not change the prescription of the eye. Rick Barnes is giving me a lot of plus signs. Chrissy, glad to see you here. Thanks for joining. Chrissy McGargy is here. Many of you have communicated via email. She is awesome at answering all of your questions and getting the information that you've been needing over the last year or two out to you. It is because of Chrissy that the people have who have become patients. It's all due to Chrissy's hard work and tremendous organizational skills. Tom asks, do you have any surgical experience with patients up to the age of 25 who are suffering from floaters in the premacular bursa region very close to the retina? Yes, I do. I have many patients who are over the age of 21 who complain of copious floaters that are both in the premacular area and in the anterior vitreous. It's been my experience that there are two types of floater sufferers. There are the patients who have had a PVD. They are usually older. They may or may not have had cataract surgery. Those floaters are generally very large and very easy to see. The other patients, and I think many of you fall into this category, have tons of floaters that cannot be detected by your doctor. They're either too small for us to be seen, or there are too many things for the doctor to see inside the vitreous, and we can't identify exactly which one's bothering you. Regardless, I'd like to just kind of throw it out there that there are patients who have large floaters that are easily seen, and the others are many of you younger patients who have lots of floaters, but we can't see them. As long as you understand what the risks, and as long as you make it clear to me that whatever you're seeing moves to and fro with eye movement, I think we have to agree that whatever you're seeing can only be located in the vitreous, and a vitrectomy should be very helpful in helping you. Chase asks, what should we say the appointment is for if we called to make one? Just let Chrissy know, or you can email me that you're interested in talking about or investigating having your floaters evaluated. Sometimes it's hard to communicate reasons without the expectation that these are new floaters and I'm worried about a retinal detachment. I think that if you were to call our office or you call anyone's office, say that you're concerned about floaters. If they are new floaters, you should try and get an appointment within 48 to 72 hours. If they are chronic floaters, then I think you have to use your best judgment with whomever you call as to when that actual appointment will take place. Jerry asks, can you address the possibility of getting cataracts as a direct result of FOV? All right, Jerry and everybody else, hang on. My short answer is I don't think vitrectomy causes cataracts. There has been a recent publication, however, that says vitrectomy does cause cataracts in patients who had pre-existing cataracts at the time of surgery. As I've said during the presentation, there are several reasons to perform a vitrectomy. You can perform a vitrectomy for floaters. You can perform a vitrectomy for bleeding in the eye, for retinal detachment, for an epiretinal membrane, for a macular hole. Many of you are here because I think you can make a generalization. Very few, if any, floater-only vitrectomies are performed. The article is looking at vitrectomies performed for all reasons, and all reasons include vitrectomies for retinal detachment and macular holes. And I point out these two entities because there's something special about those vitrectomies. Those vitrectomies include putting gas into the eye. And whenever you put gas into the eye, it will cause a cataract much faster than if an operation were never done. So the article includes vitrectomies done for all cases, including those vitrectomies using gas. And so that I think that the numbers are biased. I think that if there is no cataract present at the time of surgery, then I don't think you're necessarily going to get a cataract. Cataract formation from vitrectomy is somewhat confusing. No one knows exactly why cataracts form after a vitrectomy. Part of it may actually be related to the length of time of the actual surgery. It may be related to the amount of light from the microscope that we used for the surgery. So there are other variables that we're not sure about. I can tell you that in my experience, that in young people with no cataract, there does not seem to be an increased formation of cataract, at least in the first year. Does this mean it won't happen to everybody? No. But what it does mean that is that in most cases, I do not see cataract formation as a problem. Charles asks, what after the FOV would cause my diopter to go up 3 to 4 diopters, or 3 to 4 diopters? Another what Charles is asking is what would ask his Charles wants to know what would change his prescription to change it, I guess increase or decrease by 3 to 4 diopters. In theory, less vitreous could shift your lens. Um, Also, Charles may be developing a cataract or may have a small cataract, and this may be a case where cataracts are progressing um, without. I think Charles may be somewhat older than a lot of you and may have had cataract at the time of surgery. And maybe what he's noticing or what you're noticing, Charles, is that the cataracts are forming, uh, albeit early, and that's why it requires a change in the prescription. Miguel asks, why aren't more doctors aware of the procedure? That's a really good question, and I think it stems from the fact that all eye doctors do not know everything about all different types of eye specialties. Meaning, I do not think that general ophthalmologists or general optometrists know much about um, the retina specialty or what a vitrectomy is. I believe that if you remember when I said that vitrectomies were thought of as dangerous in the 70s and 80s, many of the people that learned that are not retina specialists, yet they're practicing, they're perfectly competent practicing eye doctors. I think what they remember was from their days of training because they don't perform this during this modern times, if you will. Um, Only the retina specialist can really appreciate the change in technology that has occurred in the last 8 to 10 years. The change in technology, which has made vitrectomy safer, is really the movement from 20 gauge, which is larger instrumentation, to 23 or 25 gauge instrumentation. I use only 25 gauge instrumentation. And in layman's terms, 20 gauge, the number 20 versus 25 gauge means that the 20 gauge instruments are fatter, they're thicker. So you need to make bigger holes in the eye to insert the instruments. The, the little port or the hole, hold on a second. Let me see if I can find a slide which will help me. This is a standard vitrectomy system. The old system was a 20 gauge system, and that meant that the thickness of this instrument was wider than say what I use or what many doctors use now, which is a 25 gauge system. There's some advantages to a 25 gauge system. It doesn't need stitches to close or open, etc., etc. But the significance is that the chance of retinal tears or causing damage to the retina is decreased because everything's smaller. This tiny little hole at the end of this instrument, which sucks in the vitreous, is smaller. which, because of physical properties, means that you cannot pull or tug on the vitreous as hard as you once could with the older, fatter instruments. So, this new technology is only around has been around at most for the last 8 to 10 years, and I do know that not every retinal surgeon even uses this technology. But the numbers or the chances of infection and retinal detachment have decreased significantly compared to the older system because of the um, newer, thinner instruments. So to answer your question, Miguel, because most doctors that you have seen are probably not retinal specialists, they're really kind of uh, educating you based on old information. Do you know Tom asked, do you know something about the blue field entopic phenomenon? It occurred with my floaters. Blue field entopic phenomenon, Todd, to me means that I guess with a blue colored light, you can see some of the actual white cells going through your own retinal blood vessels as they cast a shadow onto your retina. If that's not exactly what I mean, Tom, go ahead and re-ask the question, and I'll address it later on. I've never heard it associated with floaters. How you doing? How are you, Ryan? I appreciate your commenting on the blog and the emails. Ryan asks other long-term consequences such as cataracts, glaucoma, macular degeneration. As we said, cataracts are debatable. I think that if you have pre-existing cataracts, they may uh, form more rapidly after vitrectomy. We just don't really know. There is no association with glaucoma or macular degeneration. Uh, Hamadraza asks, do you do peripheral vitreous shaving during FOV? Um, the answer is yes, but I do not. I am not concerned with getting too close to the retinal surface uh, of the peripheral retina. I am very interested in getting very close to the macular surface, and I would estimate that we get within 1 millimeter of the macular surface. I don't think this is necessary as we move to the peripheral retina. And keep in mind, this is a technical point. The the adhesions between the vitreous and the retina as you move more peripherally, more to the side, get stronger and stronger and stronger. So, in theory, you could increase the risk of causing tears. Tom asks, what about long term effects, especially in young patients? I think, other than cataract, uh, that's probably the only long-term side effect. Are cataracts a complication? I don't really think they're a complication. Keep in mind that everybody gets a cataract. Cataracts are exactly like gray hair. Everybody gets gray hair, sometimes young, sometimes old, but everybody gets it. I know some of you are shaking your head, but in my opinion, it's true. Same with cataracts. Everybody gets cataracts. And so developing cataract is really part of the normal aging process. Whether or not you get it younger or older seems to be, I would term it more of a side effect than a complication. But that's the only possibility that I can see long term. Tom says, I've heard about problems with choroidal inflammations. Choroidal, the choroid is a layer underneath the retina. Um, it is that area that can become inflamed endogenously, and that's what we were talking about, the example of having arthritis in the eye. That's a completely different problem, and I'm not so sure vitrectomy for people that have uveitis is always the right thing to do. I think it can be very helpful. I see my friend John is here. John and I had a couple patients years ago in Baltimore where we did vitrectomy in people who had uveitis because they simply couldn't see. And in those scenarios, it was very helpful. Um, I don't think you're asking, Tom, whether, or perhaps you are asking, does vitrectomy cause choroidal inflammation? The answer is it would be very, very unusual. Dandoni asks about negative feedback I've had from patients that underwent my FOV. I know only you I know only the success stories. I believe in being completely transparent, and whatever has been published or written to me on my blog has absolutely been published. The only significant complication that we had, which was somewhat temporary, was um, we had a patient who pushed on his eye right after the surgery, causing his eye for a couple days to be hypotenuse or very, very soft. This is extremely unusual. He had some episodes of distortion, um, and what we're dealing with now is whether or not the symptoms he notices may have actually been there before surgery. So this is kind of an isolated event. He's actually coming to see us in a couple months to consider operating on the other eye. Um, most most of my statistics are probably in line with the ones I quoted in terms of infection and retinal detachment, and those are those are complications of vitrectomy for all causes. But I don't have any other complaints other than the distortion in this one case where the patient mistakenly pushed on his eye. Miguel asks, why is this surgery or solution being withheld from us sufferers? Miguel, I think it's just because of lack of information. People don't know better. I think when I was trained, and I'm 52 years old, I've been in practice for about 20 or 21 years. I do remember, even when I was being trained as a retina specialist, that we doctors generally didn't consider floaters significant a problem to endure the risks. But back then, the vitrectomy did have significant risks, and unfortunately, this kind of ignorance of improvement due to technology is just really known within the retina community, and only the retina specialists who use 25 gauge instrumentations are actually well versed enough. In the United States, I would say somewhere around 50% of us routinely use 25 gauge instrumentation. It's not ubiquitous. There are older surgeons out there that still use 20 gauge. There are younger surgeons who still use 20 gauge. So it's a very, I would say it's only those of us that can appreciate this new technology and are comfortable with it that can understand the differences. I don't think information is being withheld voluntarily. I think it's just due, for lack of a better term, due to ignorance. Eric writes in, since noticing an increase in floaters, I've also had issues with light, glare, flaring, streaking, many ways to describe it. For example, while at home and looking outside through my glass sliding door on a sunny day, I see what looks like streaks or light coming through the glass extending all the way to my eyes. If I squint, this effect becomes even more noticeable. Uh, my eyes seem to now be much more photosensitive in general. Just wondering if there's any correlation between this effect and floaters. Have your other patients mentioned this? Absolutely. Um, I think especially in the young, the floaters can cause a lot of glare, which is extremely disturbing and gets translated as photosensitivity. But many patients have lots of floaters which actually can reflect light, which makes the vision even worse. And I think if Eric, that's what you're seeing, I don't think you're alone. This is a common problem that I hear from many of our patients, especially young ones. Uh, Bill writes in, thank you, Dr. Wong. Very informative. You answered everything I needed. I am excited. Hello, Chrissy. I'm excited to meet you too. Chris writes in, after a vitrectomy, do I need to stay in a head brace for a week? What is the visual recovery time? Uh, this is also another misconception or misinformation. People that have gas injected into the eye need to keep their head in a certain position. Those people have problems with those people have had a retinal detachment or a macular hole. Gas is not required in this procedure, so therefore we do not need any special devices, or you don't need to keep your head in a special position. In most cases, vision recovers within 24 to 48 hours. Ryan asks, have you spoken with other doctors about this and found others with similar views? Um, I've not directly talked to uh, other retina specialists that have the same exact view as I do, because in my normal routine and where I work, I actually there's only one or two of us retina specialists um, that work at this operating room. Believe it or not, all retina specialists don't see each other on a regular basis. I know that seems rather coy, but um, I have spoken to others at meetings. There is certainly more and more information out there, and there are certainly more and more doctors that are considering doing this for many of their patients. So I'm not unique. Dan Dooney asks, how many FOV have you done till this day, and the success rate? Um, Without getting into specifics, I've done tens of thousands of vitrectomies, but for all causes, and I've been doing FOV or the equivalent for about, I would say, 15 years. I've been in practice for 2021, and I would say almost all have been tremendously successful in terms of the floaters. That's just off the top of my head. I don't have a complete record, but um, I would say almost everybody has been quite satisfied and happy. In 20 or 21 years, I've had one possible infection. Miguel asks, does the saline have any lens oxidation potential? Does the saline have any lens oxidation potential leading to cataracts? Oxygen within the solution. Miguel, I'm going to answer it this way. It is a saline solution, which is about 1%. The saline that is used during the operation is turned over or removed from the eye by your own eye within 24 to 48 hours. So the saline that I put into the eye is gone within a day or two, because it's replaced by the natural saline made by your eye. And I'm not aware of any oxidative potential of the saline itself. Heather wants me to ballpark the total. I would say somewhere between 3 and 500. I really don't know. We don't count them specifically. I've done somewhere between perhaps 15,000 vitrectomies, though. How many in the last year? Uh, Again, 2 offices. It's hard to say. Probably 100 or so. Dandoni wants to ask, when can you go to work after an FOV? Usually within 2 to 3 days. If you come locally, we would operate on a Friday, and I generally advise people that they can go to work Monday. Do I advise local anesthesia or general? I prefer local anesthesia. I see no reason for general anesthesia, and not just for vitrectomy. I rarely use general anesthesia at all. The recovery time is increased with general anesthesia, and you just don't feel well if you've had general anesthesia. I mean, I've had general anesthesia, so I know. So as a patient, I didn't really like the grogginess I had for the day. The procedure only lasts somewhere between 5, 10, 15 minutes. So there's really no need for general anesthesia unless you've got some anxieties about lying flat. Robert asks, does LASIK cause floaters? No, LASIK per se does not cause floaters. Uh, LASIK is generally performed in nearsighted individuals, and I would say that nearsighted individuals tend to have floaters earlier in life compared to other patients. Jimmy wants to know, what is FOV cost per eye? How long does it take for the eye to recover to normal vision without floaters? Do you perform both eyes at the same visit or separate? With membrane on the retina, how much vision improvement can one expect from FOV without going through the ERM peel? Okay, Jimmy, I don't know the actual cost of the FOV. I try to leave that to Chrissy or my other um, office managers. I try to keep away from the finances of what I do. Um, Having said that, in the United States, most insurance covers vitrectomy. If you are not within the United States, you can email Chrissy and she can tell you specifically what the charges would be in terms of my charge, the hospital charge, and the anesthesia. How long does it take for the eye to recover to normal vision without floaters? Usually within 2 to 3 days. Do I perform both eyes at the same visit? No, I do not. I'd like to make sure that we don't have any complications from the first operation before operating on the second eye. What I do, I usually like to wait several weeks at a minimum before I operate on the second eye. With membrane on the retina, how much vision improvement can one expect from FOV without going through the ERM pill? If you have an epiretinal membrane and you've got decreased vision, in addition to the floaters, uh, I'd be misleading you by giving you any guess because I have no ability to examine you, Jimmy. Um, I would say that the FOV is going to get rid of only the stuff moving around in your vision, but the blurriness that is not moving around um, is probably going to stay the same because that would be related to the epiretinal membrane. Elena says, "Dear Randy, this is Elena. Hi, Elena. We've written back and forth many times. I just wanted to thank you for this webinar. As always, it's wonderful to learn from you. Will there be a record of the Q&As on your website too? Thanks, Elena. I hope so. It just depends on how big this file is, and it may take several weeks before I get it up there. But I certainly want to have some version of this presentation either up on YouTube, SlideShare, or on the website." Heather asks, if a PVD has already occurred, then do you simply perform a full FOV versus a core? What about if one eye has a partial PVD? Do you then remove all the vitreous? PVD or not, it's hard to remove, if not impossible. It's hard to remove all of the vitreous. If a PVD is present, it makes the procedure really very, very simple because I don't need to worry about getting close to the retinal surface to, so-called shave the vitreous. Um, I don't believe there's any such thing as a partial PVD, or I don't feel I would be able to diagnose a complete PVD versus a partial PVD. So I'm not really the best one to answer that specifically. In my book, you either have a PVD or you don't. Jerry asks, are patients who've had an FOV and have developed cataracts limited to monofocal IOLs? No. There are different types of implants. Some are monofocal, meaning that they are designed or calculated for you to see at one distance, usually at distance, sorry, they're calculated for you to see at one length. Usually that's distance. There are some fancy high-tech IOLs out there that let you to see both at distance and near. These multifocal IOLs are new. It doesn't matter if you've had a vitrectomy or not. So it's a separate issue altogether. Miguel asks, will a possible later in life cataract surgery be of higher risk because of lesser cushion from original vitreous? My cataract surgeon friends tell me that they are able to tell an eye that has had a vitrectomy versus not, and do say that an eye with no vitreous has less of a cushion. This is going to be really hard to explain um, verbally, but the answer, as I understand it, is that there is overall the answer, as I understand it, is there is no issue with an experienced cataract surgeon or with a surgeon that is aware the vitreous is removed. Keep in mind that we do surgery all the time. We do vitrectomy surgery all the time for a variety of causes, and many patients have had cataracts um, as a result of uh, usually age or another disease process, and there is not an increased risk in complications because the vitreous was removed. Ryan asks, if a patient has not had a PVD, what is generally the cause of a person having so many floaters? Had a slow onset over the past 16 years, but had sudden and large increase over the past 3 years, have ruled out retinal tear and also a PVD. Um, Ryan, it's hard to really know. If there's absolutely no PVD and there's no tear, then one can only speculate that uh, for whatever reasons, um, the the optical the proteins in your vitreous, the optical properties of your proteins have changed at a different rate. That's really the best explanation I can give you, obviously without examining you, and maybe it's probably just my best guess. Um, the next possibility is maybe you have a PVD that just wasn't diagnosed. As an examiner, as a doctor, I can't always determine if there's been a PVD. Eric asks, are there any studies on the long-term side effects besides possibility of development of cataracts for a vitrectomy? I'm not aware of any other long-term side effects. The procedures, vitrectomy has been around perhaps since 1975 to 1980 at the latest. So it's been around for about 35 years. It seems to be a very helpful and useful procedure. And I think that if there is any concern about complications or side effects, then the obvious one is cataracts. Lynn asks, what is the youngest age you would recommend the operation for, and is there any additional risk? I think the youngest age is really medical legally. So I choose the age of 21. Uh, is it more dangerous at 21 than if you're 50? No, not at all. The vitreous is a little bit stronger, but it's as long as you're not inducing a PVD, shouldn't be a problem. Chrissy says, thank you. Chrissy, thanks for joining us today. I appreciate you taking your personal time to join us. I'm sure that many of people who will be writing in or talking to you will appreciate your participation today. Rick says all those plus signs were from his cat. I excuse you, Rick. Jim writes in, if floaters are caused by a recent PVD, can there be improvement in floaters over time or movement of them to the peripheral vision? The answer is yes. In most cases, it's been my experience that the floaters actually do change in location and make them less noticeable, or sometimes actually go away. Robert asks, what are the risks of increased ocular pressure following FOV, and won't your out of town patients be unable to return by air travel? Robert, the risk of increased ocular pressure following FOV is probably about 5 to 10% and might be related to the use of steroid drops, which is the standard drops used after most eye operations. This, however, does not preclude air travel. Just having high pressure simply having high pressure does not cause any problem with altitude or traveling by air. There is some concern with people that have gas in their eye, however, and air travel, but we don't use gas in this, so it shouldn't be a concern. Everyone that comes from out of town does so already having set up an appointment with their own eye doctor at home. So if there is a problem such as high increased pressure, your eye doctor should not have any problems helping you with that. If you'd like to stay in town and have me take care of you or come back, that is certainly an option as well. Um, Chris, this is from Chris, who has a patient of mine who has had the procedure in one eye, and I believe now that we've cleared up our surgical snafus in March, is coming back for his other eye. Chris says, Randy, this is Chris. Just an observation and comment from someone who has obviously seen you and had a successful outcome like many others. My advice to all of you out there who are spending your days reading blogs, forums, websites, etc. about floaters and the negative things that can occur as a result of this opposition, stop. I did the same thing for a few months, and it can scare the hell out of you. This operation with Randy was easier than having my appendix out or having shoulder surgery. The more you read about how scary a vitrectomy is, the more you're going to scare yourself. It's a simple operation with a simple recovery, and Randy is a phenomenal surgeon. This is just my 2 cents. Chris, thanks for the endorsement. I think Chris's message is really poignant in that the chance of complications from the surgery are, let's just say, 1%, and the whole internet community, I think, is focused on a bunch of what ifs or complications that could occur less than 1% of the time. That means over 99% of the time, eye surgery, even cataract surgery, is highly, highly, highly successful. There is no pain. We prefer to do it as an outpatient, so you are physically well after the operation. And as Chris has experienced, and hopefully will experience again, there really is not much to this. We're all here today because I think what we're trying to do is explain away or dispel a lot of just bad information or ignorance out there. So again, thank you, Chris. Uh, Ryan says, how many of these would you estimate you've done and what is the general result? I think we've already covered that. Hundreds, and I think the results are phenomenal. Uh, Tom Kerjet. Tom says, yes, and therefore I have communication problems with my eye doctor. Thanks. You're welcome. I think a lot of people have communications with their eye doctors. A lot of people what I've noticed is that patients who have been suffering from chronic floaters you've been shamed or discounted for so long, you're actually afraid to discuss your problem yet again because there's this natural and understandable fear that someone's basically going to ridicule you again. And I think, unfortunately, this has created a huge communication gap between yourself and doctors who might be able to advocate on your behalf, but are generally very conservative and choose not to do so. Patrick, how are you? We've also talked many times over the blog. Most doctors say cataracts will develop 100% of the time. And again, Patrick, that's kind of correct, but everybody gets cataracts. Do I agree? Do you agree? And is it true that the younger you are when you do the surgery, the longer it will take for cataracts to develop? I would have to agree with that because I don't necessarily believe that vitrectomy performed for 5 to 10 minutes really influences cataract formation, especially if there's no cataract present at the time of surgery. Having said that, the younger you are, the less likely there's any cataract formation. Dandoni asks, do I have floaters? No, I do not. Chrissy wants to alert someone, hopefully listening, that there was an issue between getting um, surgery scheduled or an appointment scheduled to one of two of my offices. If you're that patient, go ahead and email us again, and we'll straighten out the correct office. Eric asks, for out-of-town patients, how long would you expect them to stay in Virginia for post-op exams? Um, what we generally do is have you come in on Thursday and see you for an examination to confirm that the operation, which is usually performed on Friday, is in your best interest. The operation will be performed on Friday. On Saturday, we'll take a look at you Saturday morning, and after that, you're free to go. You can fly, you can take a train, you can drive. So the short answer is 2 days at the most. Come in Friday, excuse me, come in Thursday for evaluation, operation Friday, post-op exam Saturday, go home. I think I just answered Chase's question. Do out-of-state patients usually make 2 visits or one? They usually make one. For instance, do they fly in for evaluation and then come back, or plan on coming in for both evaluation procedure? Um, Chrissy and I have found that it's most efficient for you that if you want to come see us, we can schedule the appointment. We can schedule the surgery for a Friday. You see us the day before. If for some reason we don't need to schedule or perform the surgery on Friday, surgery's canceled and it's no big deal. We part friends, no cost to you. Charles says thanks. And thank you for the follow up. I'll see you soon, Charles. Patrick says, how often do retinal tears develop during the FOV? In my own experience, probably about 1 to 2%. If a tear is found at the time of operation, I can either treat it with laser or freeze it to prevent it to progress to a retinal detachment. Um, Patrick asks, what 25 gauge tools do I use? I use both the Bausch& Lomb and the Alcon. Ryan asks, what's the recovery like for an FOV? Recovery in terms of full function is about 2 days. The day after surgery, you'll come to see me, you'll take the patch off, and then we'll start some drops. Vision usually returns in 2 to 3 days, but later that day, you can basically resume full activity without any restrictions. You will be on drops for several weeks. Your vision returns quickly. So in terms of how long does it take before you won't be on drops? Probably 2 to 3 weeks. How long will it be before you go back to work and do your sports? Probably 1 to 2 days. Chase says, I have to go. Thank you so much. This was really interesting to me. It's difficult to be a floater sufferer in some ways due to misconceptions all around. I'm sure you have things to do on a Sunday afternoon like we all do. So, again, thank you very much and have a great day. Chase, thank you very much for participating. I hope you and others enjoyed it. I really enjoy the one on one, and I think it's very unique due to technology these days that patients and doctor can communicate in this fashion. Tom asks, am I aware of Professor Koch's one-port vitrectomy in Frankfurt, Germany? Um, no, I am aware of one-port vitrectomies. The problem with one-port vitrectomies is you can't see what's going on in the eye um, as well as you can with 2 ports or 3 ports. It's a lighting issue, but I don't do those, so it's kind of a moot point. Chrissy wants to say hello to Bill. Rick writes in, I've had Lasik and cataract replacement surgery. In terms of risk, what, if any, additional risks for now doing a vitrectomy to remove the floaters? And having experienced retinal detachment in my left eye, same scenario, Lasik cataract surgery plus YAG laser. Do you think the risk is higher, or is one not related to the other? Bottom line is I only have one good eye, so to speak. So I'm very hesitant. So is my wife. Rick, I think you have every right to be concerned, and so obviously does your wife. Um, Anytime you stick instruments into the eye, there's about a 1% chance of getting a retinal tear. So that means anytime you'd have cataract surgery, there was a chance of causing a retinal tear, which could lead to a retinal detachment. Um, because of your previous history, however, I don't think that you're at higher risk of getting a retinal detachment um, from the surgery itself. Um, Keep in mind your retinal detachment was not caused by previous surgery. Your retinal detachment um, occurred because of natural events occurring between the vitreous and the retinal interface. So you could make an argument that having a vitrectomy will make it less likely for you to get a retinal detachment in the other eye. In terms of infection, the risks are the same. YAG laser, I don't think there will be any issues with that as well. Ryan said, I had a doctor tell me you'd put a gas bubble in my eye. Yeah, I remember. I think you wrote in about that a couple weeks ago. He also said he would induce a PVD. Is that the reason for the gas bubble? I don't know why anybody would put gas in your eye for a straight vitrectomy. I can't imagine why you would want to do that, except that perhaps this doctor is afraid of hypotony, and some people may put the gas in to keep the pressure high, meaning the gas will plug the teeny tiny holes. This is not an issue if you insert the instruments in a particular way. And that's the best I can tell you without boring you. But I don't think gas or air is necessary at all. And again, I've expressed my view that I think inducing a PVD is not in the patient's best interest. Karen asks, can floaters affect night vision? I would say only so far as increasing glare. Miguel says, meeting like this would be perfect to be held on universities where future retina specialists are being trained. Who could start this to combat the ignorance? Um, who could start this to fight the ignorance? Um, I think with time, more and more doctors are going to become a little bit more vocal. I think with time, those that are willing are going to be able to kind of spread the word in open forums like this. I do know that I've been contacted with several young associations of young doctors to actually help them communicate, not necessarily uh, on this subject matter, but via webinars and over the computers. I think the short answer, Miguel, is I think with time, more and more people are going to be exchanging information in this fashion. Dandoni asks about future news on enzymatic floater removal agents. Not aware of any. Again, I think ochraplasmin is out there. I think ochraplasmin has a false market, meaning I'm not so sure it's a useful product. If you look at the ochraplasmin and the what it's indicated for, it fails in comparison to the surgical remedies or fixes out there right now. So I don't think ochraplasmin is going to be around for very long. Tom, I think I answered you about Dr. Cokes. I just don't know much about him. Um, I do not think palinopsia is related. I don't know how palinopsia could be related to floaters, Miguel. I'm going to try and wrap this up. I think for many of us, this is it's been a little bit, almost an hour and a half. Just got a few questions left. Jim says, does the follow-up appointment at home have to be with a retina specialist or can be with a general ophthalmologist? It can be with a general ophthalmologist, or I'm happy even with an optometrist, as long as the vision's okay and they can examine your retina to make sure it's attached and take your pressure. So those are things that the general eye doctor could do. Charles would like to comment, after having both eyes done by Randy, I can certify it is more straightforward and the results are so worth it. Thanks, Charles. I appreciate your support, and I think it's very valuable to others who want to have the procedure and who may never even choose to come to Virginia. Dandoni asks, he has been in contact with Dr. Sebag, and he is a strong advocate for core FOV and floater sufferers. I think that's good news for patients near Dr. Sebag. I believe he's on the West Coast, but that's just off the top of my head. John asks, thanks, Randy. Nice webinar. John, thanks for joining. I hope you got something out of this. I really think this is a new way that doctors and patients can communicate, and is really an efficient way that is going to become more necessary and useful in the future. Vernon says, well done, a new and effective paradigm in medical communication and education. Thank you. Eric says, thanks. Webinar has been very informational, educational. Um, thank everybody for joining and making this so successful. Christopher says, oh, I must have missed that, Chris, about being a moderator for Vitreous Floaters at yahoogroups.com. Why don't you type that in again? I must have missed that, and I apologize. Ryan says, thank you for doing this. Appreciate your taking your personal time to address this issue. Hope you are retiring anytime soon. I have 5 kids. There's no way I'm retiring soon. Patrick says, patient aware of numbing shots done before surgery? Nope. You get anesthesia, which puts you in twilight for about 5 minutes. You're completely unaware of any numbing shots. If needed, at my surgical center, if you become anxious and you need medications to calm you, absolutely you'll get them. Dandoni wants to know, will I ever use 23 gauge? No, I think 23 gauge is unnecessary. I don't think 23 gauge is small enough or thin enough, and I don't think there's any advantage to using 23 gauge over 25 gauge. In my opinion, if 25 gauge instrumentation is not good enough, I'll go back to the 20 gauge. And these are, again, not for FOVs, but for other vitrectomy procedures. I would never use a 23 gauge for FOV. Jimmy asked, do I perform an ERM peel? The answer is yes. It's actually one of my more favorite operations to do. I've got a nice video on YouTube. I think all you have to do is search Randall Wong or Dr. Wong ERM. You could email me for the link, or I may have a link on my homepage of retinaeyedoctor.com. Second question is, if yes, what's the percent rate of successful improving vision after the surgery? And if viable, can ERM peel be done at the same time as FOV operation? The answer is, I believe that almost everybody notices improvement after an ERM peel. I've had 3 cases in 20 years where I couldn't remove the epiretinal membrane. In everybody, there has been improvement in vision, especially in reduction of distortion. Remember, listeners that are still on, we're talking about ERM, which is different than FOV. But Jimmy wants to know, will the ERM peel be done at the same time as FOV? I'd have to do the FOV first before I can gain access to do the ERM. So the answer to your question is yes, I do them. And number 2, both parts would be done for the same operation. Rick says, thanks very much, Randy. Much appreciated. Gotta go. See you soon. Rick, thanks for your time this weekend. I appreciate it. Thanks also for your comments. And thanks for your cat. Tom says, many thanks for sharing your experience, commitment, and readiness to help us floater sufferers. Greetings from Germany. Very cool. Miguel says, you gave me hope to carry on with my life, doc, when no other docs would do that. They all dismissed me, telling me to live with it. Thank you for caring, Randy. We'll be seeing you in the future. I look forward to it, Miguel. What Christy and I have realized is there's so many people that can be helped. There's no reason to be ashamed or feel like you're a second-class citizen. Jim says you're awesome. Well, thank you, Jim. Everybody out there that participated. This is a pretty awesome event. Even my dad participated. Dandoni, what about the new 27 gauge? Not interested. I think the instruments are too flimsy. Jim says thanks. Dandoni says thanks. Dandoni says thanks from Holland. Patrick says thank you to Dr. Wong and Chrissy. You're friendly and helpful. And I'm going to use this opportunity to say thank you all for hanging out with us this afternoon. It's 4:24 Eastern Time. We basically went an hour and a half. We'll be sending you links to the slides. We'll be sending you everyone our contact information. You may contact us, always contact us through email or via the blog. Many thanks to Amy, my wife, for setting this up, and always to Chrissy for helping arrange and scheduling everything she does. Everyone have a great weekend. Many thanks again.